The bottom line is there is no standard of care. And by that I mean the number of patients are low, so the approach has to be individualized with each patient. The biggest issue that we confront as medical oncologists is once we are aware of a patient that has a local regional recurrence, more often than not they have a prior history, obviously, of an earlier stage breast cancer. They've gotten some form of adjuvant therapy, be it chemotherapy, anti-hormone therapy, and they could very well be many years down the line, or in particularly aggressive disease, it could be, in the midst of their ongoing anti-hormonal adjuvant therapy. So the decision that we have to make once it's been diagnosed is whether there's a role for additional different adjuvant therapy. And part of the focus of my talk was actually defining the risk of further problems. Assume that the local regional recurrence is resected. That's usually a harbinger of other microscopic disease, and many of these patients have a high risk of developing metastatic disease later in their follow-up or life. So we have to decide, do all patients need the same kind of therapy? And one of the things that we've started to do is look at the subtypes of breast cancer, not only when a patient is originally diagnosed, but also when they develop a disease recurrence. And for patients that have a local regional recurrence and you subtype them, there's a different behavior depending on the subtype. So the patients that have so-called triple negative breast cancer, hormone receptor negative, HER2 negative, that develop a local regional recurrence, even if completely resected, these are patients who have a heightened risk of another event, metastatic disease developing, and if they do, shorter survival. That's in contrast to patients that have other subtypes of local regional recurrences, hormone-sensitive recurrences, or even HER2 positive recurrences. And with that information, we can get some insights into what the optimal therapy should be. So one of the things that I sort of focused on when I gave my discussion was that we don't have a lot of data from clinical trials regarding whether or not chemotherapy helps in all patients with a local regional recurrence. And one trial that was done was the so-called CALOR trial that was initially presented at this meeting in 2012. It had some 160 patients in it, and they either got chemotherapy or not after the local regional recurrence was removed, and they were followed for now about 8 or 9 years out. So we have long-term follow-up. And where we see the most benefit from chemotherapy in that setting is in patients who have, again, hormone receptor negative or hormone insensitive disease. So chemotherapy, if it's to be used in this setting where you remove a local recurrence, there's no other evidence of disease, it's probably in the patients who have hormone insensitive breast cancer. And again, even that data set is not ideal because that trial, the only one that was really ever done with 160 patients, was meant to have 900 patients on it. So it already tells you that it's very difficult to recruit these patients. There aren't that many of them, but it does follow from other experiences. And the other sort of analogy I made is that in patients who are receiving chemotherapy in a completely different setting, in the preoperative setting, and they get less than the pathologic complete response rate, in other words, they have residual disease, who are the patients most likely to have problems in the future? It's the patients with hormone insensitive disease. And we do know from one trial, the CREATE-X trial, that patients with residual disease after receiving neoadjuvant therapy who receive more chemotherapy can have an improvement in their overall outcome. So if one extrapolates from that experience to the local regional recurrence, it follows that chemotherapy may help there. So how I concluded sort of my remarks based on the limited data that is available is the CALOR trial, which has been updated at ASCO this year, supports the idea of chemotherapy in hormone-insensitive disease, For patients that have hormone-sensitive disease after a local regional recurrence, most would advocate switching the anti-hormone therapy and continuing it. And for those patients who have HER2-positive local regional recurrence, we would resume anti-HER2 therapy, probably with a different recipe. And there remain obviously a lot of questions. Which is the best chemotherapy? How long? If you use anti-hormone therapy, how long? And if you use anti-HER2 therapy for HER2-positive disease, what's the best treatment and how long? So there's a lot of questions that can't be answered by guidelines or clinical trials, simply because this particular situation is relatively uncommon, and no center, no trial will ever have enough patients to adequately address it the way we do typical things in clinical trials.